Paul, once more, congratulations to what you have done. Really, this is a very impressive audience, and of course, the success of the meeting is you. And I see very enthusiastic group asking good questions, and I am truly impressed coming from Cincinnati to here and see you in for the first time this conference, and how you've been engaged, asking questions. Congratulations to all of you, and thank you again, Paul, for doing this. I hope this will continue. All right, now we are talking about opioids. Chronic non-cancer pain conditions. Chronic non-cancer pain conditions. So as you may all know, opioids are now being used extensively in this country as well as elsewhere, and for a variety of reasons. And I want to come back to this position, a statement a little bit later on. So in the last few years, use of opioid has become part of the management of chronic and non-cancer pain. And this was the 1997 position statement by the American Academy of Pain Medicine as well as Pain Society, and that's what they said. That it is acceptable to use opioids for the treatment of chronic pain with minimal risk of respiratory depression. So now use of opioids for patients with both acute and chronic pain is safe and more effective than ever before, and a big smile. Institute of Medicine, Relieving Pain in America, and that's the website. In this country now, 116 million Americans with pain persisting for more than weeks or years. And the use of oxycodone and methadone have increased close to tenfold over the course of the 1997-2003. And the overall financial cost here, we're talking about, I talk about heart failure, $40 billion, $560 billion. In case you don't know, here are the top 4 medications used in this country. Antidepressants, lipids, narcotic analogs. Then the antibiotics and so on and so forth follow. So we are dealing with huge amount of opioids used in this country. Huge. Now, with this, there is a parallel increase in death. And this is one of the papers that I thought I'd bring up to your attention, because in Canada, they really take good records of people who die, which is interesting. Death is cheap, remember? So if you look at the 1991 to 2004, you can see here was long-acting oxycodone added to drug therapy, and then these individuals, 34 to 48 years old, annual number of deaths per million, 24% suicide, 54% undetermined, and 22% unintentional. So, big number of people, young individuals who die. And most of these people die in bed. You remember Heath Ledger? This man is a thin man. And at 12 noon in New York, in the hotel, the maid goes in, and this man is on his belly, and he's snoring. And then 3 hours later, the man is dead. And at autopsy, no cause was found, which is exactly what it is in all these people who die on opioids. And the only thing is multiple drugs in the blood. So, deaths and opioids. I call it death in bed syndrome. Death in bed syndrome. Opioid analgesics are now responsible for more deaths than the number of deaths from combined suicide and motor vehicle crashes. or cocaine, etc. And again, as I mentioned, there's a parallel increase in the number of deaths with the number of opioids prescriptions. The majority of deaths occur in patients given prescriptions based on prescribing guidelines by medical advice, by medical boards. And a lot of deaths are in low-dose opioids. So what is the cause of death in so many patients on opioids? I would suggest that terminal apnea is the sine qua non of death in opioids. This would be like Michael Jackson, who was given propofol and eventually had a terminal apnea and succumbed to death. With opioids, we have obstructive sleep apnea, we have central sleep apnea, we have hypoventilation, and a lot of these patients are on combo drugs, such as benzos, you will see, as Heath Ledger was, and the combination really could be lethal because these drugs work on different neuronal aggregates involved in control of breathing, which I will talk about a little bit, and they may impair arousal. So the person, this young individual, may be taking regular prescription dose and take a breakthrough dose and then unfortunately stops breathing, does not wake up, and they die. So let's go back to the statement, and here is what I say. Although they were right that with chronic use of opioid, there is some adaptation, there's a plasticity in the brain, and therefore hypercapnia, certainly severe hypercapnia, is not very common. There may be mild hypercapnia. A lot of them are upper normal limit PCO2. So daytime hypercapnia is not, the mild hypercapnia and eucapnia, upper normal limit, is very common in these patients. So there is adaptation here. One thing that, of course, doesn't go away is constipation, which just stays there. It's a big problem. Now, when these statements were made, there were no polysomnographies on these patients on opioids. And then a number of us came around and started doing polysomnographies to see what is going on at night. And then we come up with the statement that, well, you may be right that there is not much respiratory depression during the day, but wow, let's look at what is happening at night. And I want to show you a couple of patterns here. And what is this patient's problem? I'm sorry? What's that? Congestive heart failure and periodic breathing, right? And what about this one? You can see central apneas, another central apnea, maybe hypopnea. You see a little bit difficulty here. Hypopnea, maybe hypopnea, central apnea, another central apnea. What do you think about this one? Cheyne-Stokes? No. Opioids. There is a big difference between this pattern and this pattern. When I published this, the reviewers actually came back and said, would you please label the events here so that we know what they are? Because it is sometimes very difficult to really exactly know what the event is. It is very erratic. Central apneas of various durations, in contrast to heart failure, you see. In heart failure, CSA, 30 seconds all along. Out of apnea is gradually increasing, then gradually decreasing. Again, apnea, gradually increasing. Here we have erratic breathing. Sometimes out of apnea, you can see 4 breaths like that, cluster breathing. Another short central apnea, then 4 breaths here, a little breath here, a short central apnea here. Maybe it's all hypopnea. So it's a very difficult polysomnography to really score. And so you really have to spend time to score these studies. And unfortunately, that takes a lot of my time because I'm a perfectionist person. And the EEG is screwed up, and a lot of alpha wave here and there, and so on and so forth. So you need to really be careful. And for example, here you can see this is these are where the arousals occur. In fact, at the peak of hyperventilation, very similar to Cheyne-Stokes in that regard, that the arousals occur when the patient is breathing like that. So we have OSA, we have CSA. So in the next few minutes, I'm going to show you these particular issues regarding the opioids. I'm going to tell you that sleep apnea is more prevalent here, more severe. CSA is more common. There is no gender predilection. Thin OSA common in thin people, and age is not an issue. So it is a completely different phenotype than regular OSA in general population. We'll come to that in a moment. You all remember that less than 5 is normal AHI, and 5 to 15 is mild, 15 to 30 moderate, less than 30 moderate, above 30 is 30 or severe sleep apnea. Okay, so we have 2 excellent studies from Wisconsin that was updated just recently. The first study is the Terry Young study in the New England Journal of Medicine, which was collected in the late, mid-80s. And that was the study that showed that 2% of women, 4% of men have obstructive sleep apnea syndrome. And that in that study, also it was shown that 26% of men have an AHI of 5 or more per hour, and 9% 15 or more per hour. Now, this is now serial PSGs on the same individuals. Now, so the current estimates of sleep apnea in this country is in the American Journal of Epidemiology. Now the first author is Peppert, the same investigator that was with Terry Young, and now the prevalence has gone up. So now we're talking about 34% of the American men have an AHI of 5 or more per hour, and 13% of women have an AHI of 15 per hour, and we are twice higher AHI than women. So in women now we're talking about 17% and 6% having AHI of 5 or 15 per hour. And we come to these numbers frequently in the next few slides. And again, as we get older, the AHI will go up. Men more than women, obese people more than thin people. So that's the typical phenotype of OSA in general population. Now let's look at some of the studies on opioids. So this is a retrospective study of 98 consecutive patients. It's retrospective, but that's consecutive. And you can see that 85% have an AHI of 5 or more per hour, and 50% have an AHI of 15 or more per hour. Now remember, in general population, 13% of men and 6% of women have that AHI. So sleep apnea is more severe in the opioid patients. And then central apneas start to come into the picture. Because in general population, central apnea is less than 1%. You rarely see this kind of CAI unless something is going on, such as opioids. And then look at this. Now women, 41 of the 98 individuals in this study are women. And we're going to look at this study now. This is one of the good studies performed in Utah. These are 392 consecutive patients in this pain clinic, and they told them, you need to do sleep studies. And then 140 came to this lab, the rest went somewhere else. So this is the results of these 140 patients. And again, 75% have AHI of 5 or more, 50% have an AHI of 15 or more. Again, 13 versus 6 in general population. Central apnea, at most 1% in general population, and look at the central apneas now. 5 or more per hour, 15 or more per hour, 30 or more per hour. Wow. And again, women are here. Look, a lot of women here. A case control study from Australia. So we're talking about a global problem here. It's not just United States, it's a global problem. And again, 50 patients, 25 women. And they had a control group that were matched, and then the CAI, of course, is less than 1. And look at the prevalence of sleep apnea. Again, 20% CAI of 10 or more per hour. This is, again, another study on methadone. Here is methadone. Yeah, this changes. Methadone maintenance programs. And again, you can see there's a lot of central apneas protruding into the polysomnography. A lot of women. This was a home PSG. I just brought it up that's a home PSG. Okay, then came this drug. This is Suboxone. And again, the same statements were made that this is a safe drug. It is good for patients on opioids. You can give them this, and it doesn't have respiratory depression. So Dr. Farney did a very, very good study here, and this is now 70 consecutive patients on Suboxone. Look at the mean age, 32. Look at the BMI, 25. 60% female. And average AHI is about 20. Half of it is CAI and some OAI. And here is the breakdown. He was kind enough to give me the individual values, so I made this chart. So we have 33% of individual on Suboxone now having an AHI of 50 or more per hour. And of course, a lot of central apneas. And remember, these are thin people. They are very young individuals, a lot of women. A completely different phenotype than the regular OSA, which is older, more obese, and more men, and not much central apnea. So it is a different disorder. It's a different disorder. So here we go. Sleep apnea is more prevalent, more severe than general population. CSA is very common, and there is no gender predilection. And then you could be thin and have sleep apnea. Well, you take opioids, you're going to have it. It doesn't matter who you are. That's the bottom line. Okay, so I have shown you data that a lot of these people die in bed, and there is no cause at autopsy, and that except the opioids are highly prevalent. And I've shown you data that we have severe sleep apnea in this population. And we don't have data on hypoventilation, which I think is going on. Unfortunately, there are no good studies on hypoventilation in these patients. And the question is then, how do we treat this? Okay, I don't know. How many of you actually deal with patients on opioids? Can I see a show of hand? Wow, okay. Have you ever been successful in the first attempt here? You know, I have one of the patients I'll show you is a physician who works in a pain clinic. And he came to me for a sleep study, and he eventually asked me to write a newsletter that they have about sleep apnea. And I really tried very hard to taper his opioids because he was a physician, he knew what was going on, and definitely we failed. I say we failed. I don't want to blame him. It was, he knew what's going on, and he could not do it. He said, "Doc, I can't do this. I have tried. Pain comes back, and I can't do it." Yet, there is no study that indeed show that in the long run, they are effective. If you read the report by the American Institute, you will see exactly what they say. Okay, so then the question is, you know, what are the other options? And as you all know, and I've alluded to, I have done all of these in heart failure. I have done randomized trials on these medications. And recently, we have started to use phrenic nerve stimulation for central sleep apnea in heart failure. It's a project going on in the country, and we have two patients on opioids with phrenic nerve stimulation transvenously placed in one of the veins, and the phrenic nerve goes over the vein, so you can stimulate the phrenic nerve from inside the vein and help central sleep apnea. Having said that, there's again not much data here on opioids, so where we are is positive airway pressure devices. This is where most of the studies are, so we're going to go over that together. Okay. First, we're going to talk about obstructive sleep apnea. So this is a study from Stanford. Guilhem Minot and Michelle Cow are the authors here with a couple more colleagues. And these are about 40 patients that were on opioids. And look at the BMI, 25.5. And they were diagnosed with obstructive sleep apnea. And they had no other cause of the obstructive sleep apnea. And this is the way it happened. So they had enrolled the subject, they had the CPAP titration on them, and if they got less than 5, discharged. If more than 5, they went to bilevel titration. If it got less than 5, discharged. If it got more than 5, they went to bilevel with a backup rate. See what happened now. Okay, so there are 42 patients here, and on the diagnostic PSG, AHI is 44 per hour. And look at the mean AHI in the 31 of the 42 patients, the AHI was 30 or more per hour. So severe obstructive sleep apnea. And they don't have much central. Again, the central apnea index is 0.6. So this is a typical OSA patient, severe OSA, except that they are really, the body mass index is only 25.5. So with that body mass index and no other disease, they have severe OSA with an AHI of 30 or more per hour. So you can see the connection and where I'm coming from here. Okay, they go CPAP titration, and here is the pressure around 14 centimeter of water, and all the OAHI goes away, and then what happens, we have CPAP emergent central apnea. So the central apnea index is 14 per hour. I would call this CPAP emergent central apnea rather than complex sleep apnea because, as I mentioned to you, it is not specific to a CPAP. It occurs after tonsillectomy, it occurs after tracheostomy, and even oral appliances. So it's an emergent central apnea, and these are probably people with high loop gain. And Dr. Lee Chong talked about high loop gain. So these are people that, a subset of individuals with high loop gain to begin with, and then they are treated for obstructive sleep apnea, and they develop this complex sleep apnea, and then, as I mentioned before, we have shown that in most of the people this goes away. With the tracheostomy the same, it normally will go away. A subset of them, however, does not go away, and the ones that doesn't go away, one of them is opioids. So as you can see here, they developed emergent central apnea, and we have brought them back. I'll show you that later on. We brought them back and we demonstrated it doesn't go away. But these authors decided to go to bilevel. And you know that I don't think they should have gone to bilevel, because you go to bilevel, you're going to ventilate them. And when you ventilate someone with central apnea, you can lower the PCO2 towards or below apneic threshold. And this respectively will cause either hypopneas or central apneas. Anyway, they did that, and of course, the central apneas did not go away. And then they went to bilevel with a backup rate, and the central apnea index decreased, as you can see. And here is the central apnea index on the y-axis, and that is the, remember the diagnostic PSG, the central apnea index was 0.6 per hour, AHI was 44 per hour, and then that's with the bilevel, and then the bilevel with backup rate. So that worked for them, the bilevel with the backup rate. So there are, again, two forms of central apnea here with the opioids. One would be the ones that is emergent, and then the one that actually you have it on the initial polysomnography. Now I want to talk about this group here. The CSA is present on diagnostic PSG. All right, and you can infuse naloxone, and that will take care of it, which really indicates that opioids were the cause of the central apneas. And here is naloxone, and here are some of the opioids. You can see they're very structurally similar, and therefore you will have inhibition at the receptor site, the mu receptor site, where the receptors are, and the central apnea could be reversed. And here an example of naloxone that was infused. So here is morphine was given. This is ventilation, and at this point, either placebo goes on or you give naloxone, and you can reverse the process. But naloxone, you got to give it intravenously, and it goes away fast, so you have to continuously infuse it. Of course, that's not applicable. Oxygen. Does oxygen work here? It is very interesting. Opioids depress hypercapnic ventilatory response. So this is Tactile study. The late Dr. Tactile, he passed away. He was an Australian physician who did a lot of early work on opioids. and God be with him. HCVR is diminished compared to the control, but he showed that they have augmented hypoxic ventilator response. No one else has done this study. No one else has done this study. This needs to be confirmed. And if indeed they have increased HVR, that means they have increased loop gain. The loop gain has three components, as Dr. Lee Chong described. And one of the components is how extensively you respond either to low CO2, to high CO2 or to low O2, and therefore an increased response to HVR, to hypoxia, or an increased response to CO2. That means you are a high loop gain person. So if somebody is high loop gain person, indeed, if you give oxygen, that can improve central sleep apnea, as it does in heart failure. But nobody has studied oxygen with opioids yet. Okay, so we started to look at this with the pressure, with the positive air pressure devices, and the first time I did this was several years ago, and I was referred by patients were referred to me for OSA. They were on opioids, but actually all of them had central apnea to begin with. So again, this is not OSA. This is central apnea on diagnostic PSG. And here you can see again how this whole thing looks like. So here are central apneas, a breath here, and then a central apnea, a couple of deep breaths, another short breath. It is a very, very erratic, ataxic breathing, cluster breathing, biot breathing. I think most of it, what I see, is cluster breathing, which is, you see these three big breaths suddenly coming after an apnea. So this patient went on CPAP of 5, 10 central apneas persist, you can see. And we now published 20 consecutive patients that came to me because they were thought to have obstructive sleep apnea. And you can see we are a little bit heavier in Ohio than patients are at Stanford. The BMI in Ohio is high, 34, and that's the neck circumference. And again, really looks like a phenotype of OSA. I mean, they are 13 male, habitual snorer. A spouse said they have witness apnea. They get up for nocturia, a common symptom of OSA. Wake up not refreshed. They had hypertension, and some had depression. Really a nice phenotype of an OSA patient. And in addition, I'm taking a very detailed history from these patients, and they fall asleep while TV, reading, and driving. So 16 of the 20 were driving and falling asleep. This is the mean Epworth with a mean standard deviation of 4. Remember the mean Epworth, normal mean Epworth, the average was 6 with a standard deviation of 2. So the upper normal limit of Epworth is 1 mean plus 2 standard deviation, which is 10. That's why studies use above 10. And these patients are on all kinds of opioids, some of them more than one, a lot of them more than one opioid. As you can see, this is more than 20 when you add them up, because they are taking long-acting opioids, they are taking for breakthrough pain opioids, and then they are on tramadol, they are on benzos, and it is very, very unfortunate situation. It really is. I feel so bad for them. Okay, so the first 9 consecutive patients, this is what happened. So this is a clinical practice here. So the baseline AHI is 45, CAI is 20. They went on CPAP, and AHI went down to 34, and CAI went to 20. So at this point in time, I had this thought. You remember I published a study where I showed that if you have central apnea on CPAP, it normally will go away. So I said to myself, let us continue the CPAP for a few more weeks, and we bring them back and we'll see how things are. So the first 9 patients came back, CPAP number 2. It's now several weeks later. They are using the device. I have the adherence, and look at still severe sleep apnea is persistent, and also the central apnea index remains very high. So at this point in time, I said, in contrast to heart failure patients, where 50% respond to CPAP, none of these patients are responding to CPAP. I said, I'm not going to waste our money and time. I'm going to stop using CPAP on opioids. So this is now my current position. Any patient with opioids with central sleep apnea on diagnostic PSG will not be given a CPAP titration night. I will directly go to ASV device. This would be in contrast to my position in congestive heart failure, where we've shown and others have shown that 50% of those of heart failure patients with CSA will respond to CPAP and will survive long. So this is, to me, is a little bit different disorder. And again, please go to chest. Dr. Chung presented very superficially, maybe touched the tip of the iceberg about these devices. These devices have completely different algorithms. They respond to hypopnea differently, and it wasn't obvious on the slide. In fact, there was a mistake on the slide that the ResMed device EPAP was manual, which is incorrect. EPAP in both devices now are automatic. So they are having these three features in common: automatic EPAP, automatic pressure support, automatic backup rate. Those three devices, these are the common features. But how respond to apneas and hypopneas are completely different from each other. Completely different from each other. So you need to know which device you're using and what it does to respond to events. For example, another error that was on the slide is that if you use a ResMed device, the EPAP does not respond to obstructive hypopneas. Only pressure support will go up. If you use Respironic device, the pressure support will go up twice, and if it doesn't work, EPAP will go up. A completely different ballgame between the two devices. So you really need to read the paper very carefully. It took me 2 years to figure out what is going on with these devices. And if you do not know what is going on with these devices, you end up giving benzos, Diamox, oxygen to take care of the residual problem. But if you know how the devices are working, I don't think you need to do those things. So in our lab, this is what is happening. When I have the patient, I take the device, which one it is, doesn't matter. I set the range of the pressures because they're all automatic. I set the range, I give it to my technician, I say, you do not touch anything. You let the machine run. If there is a problem, you can see that's happening, you can call me and I'll tell you what else you need to do. And once you keep going on, technicians really will learn how to work with these devices, and most of the time they don't need to do much because the devices are working beautifully on the algorithm, which is all automatic. They respond appropriately to things, but you should know which device responds to what event and whatever. So again, I cannot emphasize the importance of the differences between these devices. I guess I need to make a very important point about another thing that was mentioned, because I don't want things to go bad here, and that is that when there is upper airway obstruction, at the end of the exhalation, because in some of us, the airway will close at the end of the exhalation. And if that happens, the pressure support should really keep going up to augment ventilation. However, if the EPAP was able to go up by 1 or 2 centimeters of water to keep the airway open at the end of the exhalation, the pressure support that will come in for the next breath would be minimal. So we need to give precedence to EPAP more than anything else to make sure the upper airway is open at the end of the exhalation, so that the next pressure support, the amount of that is not going to be excessive to really wake the patient up and cause arousal and so on and so forth. Again, there are 2 papers here detailed on the algorithms and how you should use it for the phenotype of the disorder. So for the heart failure, there is one set of settings. For opioids, there's another set of settings. It is very simple. It's all set and done there. You just need to look at it, understand it, and go after it. So this was now an ASV patient on opioids, another one. And I have used both devices, by the way. Okay, so this is what happened. So we have 20 consecutive patients that had CAI of 5 or more per hour, and 4 of them were emergent, and then 16 went on CPAP, number 1. 4 to 6 weeks later, 9 of them came back, and they had a lot of sleep apnea, as you saw. So the rest of them, I stopped. I said, look, we are on a go to ASV. And this is what happened. This is in Journal of Clinical Sleep Medicine just a couple of months ago. This is the AHI, 61, 50 on the CPAP number 1, 27 on CPAP number 2, 11 first night. This is the first night titration now on ASV. The central apneas, as you see, this is central apnea index on CPAP 1, CPAP 2, and virtually all were eliminated on ASV. These are the pressure settings. For example, here is one difference between the phenotype of the disorder. If this was heart failure versus opioid. If it was a heart failure patient, I did not need an EPAP to go to 12, 13 centimeter of water. That would be harming my patient with congestive heart failure. By increasing intrathoracic pressure, decreasing the venous return, and decreasing the stroke volume, especially at night, when all these things go down anyway, physiologically. So my range would be lower. See, here is 5 to 15 centimeter of water. So most heart failure patients do not need this kind of EPAP. 8 or 9 would be probably the maximum I would choose for them. Now, the minimum pressure support. Remember, these devices now are automatic. So the question was asked, I think somebody up down there asked the question about minimum pressure support. So now we have a range of pressure support. So you can choose 0 in both devices, or 2, 3, 4, 5. But there is a default on the ResMed device, which is 3, but not on the Respironic device. It is 0. So again, you got to know these things. So for the opioids, I will choose a minimum pressure support of 5 because these patients are, in terms of their PCO2, are a little bit on the upper normal limit or a little bit hypercapnic. So I want to ventilate them above the expiratory pressure support. So whatever the expiratory pressure support is, say it is 9, I'm going to put the minimum pressure support of 5, so they will always get 5 centimeters of water above 9. There was an error that was made before that you have to change the minimum pressure support. No, the minimum pressure support will always remain 5 centimeters of water above the expiratory pressure support. So as the expiratory pressure is going up, because the patient has hypopnea, for example, or obstructive apnea, the minimum pressure support always will be 5 above that prevailing expiratory pressure. Now, you can manually change it, but if you don't change it, that 5 centimeters of water always will apply. It will always be above whatever the prevailing expiratory pressure is. And then you are choosing a maximum pressure support. So that pressure support is between these 2 limits, the minimum and the maximum. It's going to vary between those 2 limits. And that is what I was answering to your question when you talk about ASV versus a BiPAP or a bi-level, where you have fixed pressure support. Here you are dealing with a variable pressure support. So if there are hypopneas, for example, the pressure support will go above 5, which was the minimum pressure support, to 6, 7, 8, 9, or 10 if that was the number you chose. And normally you can choose a maximum pressure support of 8 or 10 centimeter water above the minimum pressure support. You give the range for the device to work on in case of, for example, hypopneas. And that is very simple. If I have an obese patient with non-compliant chest wall, the kind of patient that Dr. Hill was talking about, I'm going to use a minimum pressure support of 5 or 6 centimeter of water because I'm going to ventilate them. If you have a heart failure patient who is thin, I'm not going to use a minimum pressure support of 5. I'm going to probably choose maybe 2.5 centimeter of water. So these are where you have to see the phenotype of the patient, the phenotype of the kind of the sleep disorder, and then set your pressure settings on the ASV, give it to your technician and say, these are all automatic, just let's see what will happen that first night. And remember, both with CPAP and ASV, you don't have to 100% correct the whole thing on the first night. You take the patient out of danger, and you send the patient home on comfortable settings, bring him back X number of days later on, and look at the download and see what the download is telling you, because they all have downloads now. If the download is telling you an AHI of 10 per hour, the patient is doing very well, you're done. You may want to choose a little bit more settings if you do, but if you're not knowing the algorithm very well, you let things go. But if the patient is not doing well or the download AHI is out of whack, then you have a problem. But if the two are moving along the same direction, i.e. low AHI, patient is doing very well, we have no problem. So the importance of this study is that we followed them long term. So with 20 patients, one patient refused ASV. That's that person I was telling you about in the pain clinic. And then 2 were lost to our follow-up. And so we followed him for between 9 months to 6 years. And this is the mean long-term adherence. This is a very good number, I think, 5 hours, unfortunately, biggest standard deviation. And the download AHI is 3.3 per hour. Now, let me make a comment about the download AHI. You should all know that this is a flow-dependent AHI. This is not an AHI based on an arousal, based on desaturation. It's a flow-dependent AHI. And the two devices are using different criteria for definition of an apnea or definition of hypopnea. So again, this is in the paper. You can see that for yourself, so I don't have to repeat them here. So you can't compare the AHI from Respirant machine to the AHI with the Respironic machines because they are using different criteria. Unfortunately, the Epworth did not drop as much, and that was disappointing to me. And I guess I'm not now too surprised because of the opioids are being used, and that is causing some. There was some improvement in the Epworth, but not a lot. Well, this is now a very recent study out of Stanford, and this study is a randomized trial, and I just wanted to review that with you, and these are the criteria of getting into the study. So they are on ASV auto and bilevel ST crossover, and they studied again. And what the authors are saying is that on the final analysis, looks like ASV auto versus the bilevel ST were significantly different. But I think Dr. Hill was talking about another study where you can jack up something and maybe the bilevel would be similar to the volume assured ventilation. Here you could argue that if the backup rates were different, maybe they would not be different. But this is very different from what they were saying before, because before they were saying the bilevel with backup rate was good, but now they are saying that the bilevel is not as good. Okay. Now, my main concern is post-op. You know, this paper just published. 3 sudden post-operative respiratory arrest associated with epidural anesthesia in patient with sleep apnea. FDA now has a letter out because some individuals died, actually children died after tonsillectomy. They were given opioids. So there is really a major concern for me now that these individuals, especially those with sleep apnea to begin with, they go for surgery, especially the upper airway surgery, and they are giving the opioids for pain, and they could arrest. These people may go home on opioids, and you know, when you are in a hospital for operation, your REM is suppressed. On the 3rd night at home, you have REM rebound, and that could be a potentially dangerous night for some of these patients, especially if they continue to be on opioids. So there's a lot of stuff going on here that we really need to be careful as clinicians to make sure these young individuals who come for operation will go home safe without endangering their life. So I have proposed a protocol for patients with sleep apnea, particularly for post-op care. But where we go with that, I am not sure. So I have a few more minutes to, I don't know, what time is that? Oh, I have about, how much more time? Oh, I can, all right. So let me tell you about the mechanisms of how opioids are doing these things to our poor patients. And you all aware of the G protein receptors. How many pulmonologists here? Pulmonologists? Oh, only one. So, okay. So we use beta agonists, for asthma, and they work on the same receptor. This is a super family of receptors, the G protein couple receptors, and opioids work on these receptors. They have 7 transmembrane. You see 1, 2, 3, 4, 5, 6, 7, and then the agonist combines with this here, and then things happen. Some signal transduction, cyclic AMP, DAG, inositol, 1,5-phosphate. These things change. So beta agonists stimulate these receptors, and cyclic AMP goes up. It is the opposite with the opioids. With the opioids, what happens is they work on certain channels, and eventually cyclic AMP goes down, and with that, neuronal depression occurs. And I just don't understand, somehow evolutionary, why we have opioid receptors all over our body. They're everywhere. And the ones that I think are obviously don't make sense to me are on the respiratory centers. The respiratory centers are full of opioid receptors, particularly the mu receptor, which is the one involved in respiratory depression. There are 2 sites that are very important. One is the hypoglossal motoneuron pool, and one is the pro-Boessinger complex. I'll talk to you about this pro-Boessinger complex in a moment. Here is a picture from a chapter I wrote, and this is the brain stem, and we have the respiratory centers here. So we have pons, medulla, the spinal cord, and then the phrenic nerve and the intercostal. This is the so-called ventral respiratory group. This is the dorsal respiratory group, nucleus tractus solitarius. And in the VRG group, we have the Boessinger complex up here, and just before that, it is a small aggregate of neuron called pre-Boessinger complex, appropriately. And this pre-Boessinger complex, it is like the SA node for the heart. That is where Feldman and others think that the respiratory rate is generated. So it is the rhythm generator for breathing. It's like, again, SA node for the heart. This is a pre-Boessinger complex. And if you look at it on a lateral view, you can see this is the VRG group, and rostral VRG, caudal VRG, and then the Boessinger complex here, and that is the pre-Boessinger complex. And a lot of mu receptors are in here, in these neurons. And when these neurons are attacked by opioids, I say attacked by opioids, the rhythm generation stops. And that will cause a central apnea. So this is really a different mechanism of central apnea compared to, say, congestive heart failure, where we talk about the loop gain and so on and so forth. Although loop gain may also be involved a little bit, as I showed you with the hypoxic ventral response. So what evidence do we have for this? Let's talk about obstructive sleep apnea, how opioids can cause obstructive sleep apnea. As I mentioned to you, they also work on the hypoglossal motoneuron pool. This is a study in J. Physiol, and let me show you. This is a very, very excellent study. So here is a bunch of rodents, and they are breathing here, and they have a needle in the brain, in the ventricle, so artificial CSF is going on. This is the blood pressure, diaphragmatic, genioglossus EMG, and then this is the EEG. This is fentanyl now, which is applied at the pre-Boessinger complex. So it is very selective selective thing. And this is 1 micromole, 10 micromole, 100 micromole. You can see that as the dose of fentanyl is increasing, there is not much change in diaphragmatic EMG. However, the genioglossus EMG is gradually decreasing. At this moment in time, naloxone is applied to the nucleus. You can see there is an increase in the genioglossus EMG. So there are 2 spots in the brain. One is the hypoglossal motor neuron pool, which of course is controlling the genioglossus muscle. But then there is another spot in the brain, which is good. It is redundancy. This is there's really something good that we have several centers here that also controls hypoglossal motor neuron pool, and both of them are affected by opioids, causing decreased genioglossus muscle activity, promoting obstructive sleep apnea. So the other thing they did, which is again very interesting, they gave IV administration of fentanyl, and I'll show you the data, and then local application of the naloxone, and look what happens. Here is respiratory rate. Of course, these are rodents, and they're breathing pretty fast, about 50 breaths per minute. And then this is diaphragmatic, genioglossus EMG, and that's the blood pressure. So now the CSF is kind of going through the preboceal complex. But the fentanyl is given intravenously. You see? Fentanyl is IV here. And with that intravenous infusion of fentanyl, look at the respiratory rate. Significantly drops, which is exactly what they do, respiratory depression. The EMG of the diaphragm really changes minimally, but the genioglossus muscle is really significantly decreasing. The blood pressure goes down, typical of opioids, of course. Now, when they give naloxone at the site now, this is just at the site of preboceal complex, which is only respiration, you can see the respiratory rate returns to normal. Genioglossus muscle EMG has gone down and now comes back a little bit better, but the hypotension does not improve because that is a different center. So this is the selectivity of and the beauty of this study that shows a specificity of the drug where it's working. And again, if you look at the respiratory rate, here is baseline. You can see the respiratory rate decreases tremendously, and most of it is expiratory time. You see, here is respiratory rate going down significantly, returning back with naloxone. Inspiratory time doesn't change that much, but the expiratory time is prolonging. So that is really analogous to a central apnea, because remember, central apnea is a long expiratory pause in a way. You breathe, you stop breathing. A long expiratory pause. So this is analogous to a central apnea in human. Now, what about the central apnea? Again, a very similar thing. They showed that the respiratory depression with central apneas. So we have preboceal complex, the hypoglossal motor neuron pool, both full of opioid receptors, and one involved in central apnea and the other in obstructive apnea, and both are depressed, and therefore opioids produce this complex sleep disorder breathing. Now, again, from the study that they did, which is in this one is neuroscience, the depression is most pronounced in the state of anesthesia and sleep. You can see that's why people die in a sleep, or that's why people die under anesthesia if they have a problem to begin with and they are given opioids. The effect is, so during the wakefulness, the effect is not that much. But when you sleep and when you are under anesthesia, then we have a different story. Now, how many of you saw the movie Matrix, by the way? Yeah, you remember Morpheus? Yep, yeah. So Morpheus was one of the many sons of Hypnos. Hypnos was the god of sleep. So somnus and Hypnos, hypnotics, polysomnography, that's where the word is coming from. Somnus, the god of sleep. Somnus was, or Hypnos or Somnus, this man was very, very smart. He was the god of sleep. He could put all the gods into sleep. And he had a very good sleep hygiene. You know, there would be a river here. He would go to bed and sleep a lot. And I told you, he's very smart. He was very smart. And why do I say that? You know who he married? He married the god of night. and you're the god of sleep, with the god of night, you go to bed a lot. What do? You have a lot of children. And they had a lot of children. And one of the children was Morpheus. And remember, in the Matrix, Morpheus would come to the people's dream and do all kinds of things. And that's what morphine and Morpheus, the whole thing comes from. And I like this family very much because they set the stage for us. Look, the uncle is Thanatos, who's the god of death. So the whole family, god of sleep, god of night, and god of death, really set the stage for how, unfortunately, people on opioids will die. Thank you so much for your attention.